Hey everybody, it's Adam Farkas. Welcome to another ODwire webinar, and thanks for coming out. Before we get started, I just want to go over some ground rules. So if you have any questions as the evening unfolds tonight, feel free to type in the little box on the right side of the screen that says questions. Type in your question and I'll hold it aside. And at the very end of the talk, I'll ask the speaker the questions verbally. So we'll have a little back and forth. Other thing to know, I know that here at ODwire, we were giving away a Starbucks gift card for people who attended tonight. So what I'll be doing is I'll be emailing those out to you tomorrow. So I have your email, so don't worry about that. It'll all go out to you. So with all that said, let's get to the topic of the talk tonight, wellness. So, you know, time really flies. I remember when OCTs were brand new devices, and, you know, back then they were exotic pieces of hardware. The scans were relatively slow. The output was somewhat cryptic. People didn't know what to do with them. And the only patients who were really exposed to it in the beginning were those with frank pathology that you wanted to evaluate further. But what we're seeing now as the tech has improved and availability has improved is that wellness has become a real thing where you can try to detect abnormalities before they're readily apparent to you in your clinical exam. And the latest generation of OCT can also do things like create output that patients can use to help them understand their pathology. And most importantly, you know, doing these sorts of wellness scans can also give you other revenue streams to offset the cost of any OCT that you might implement. So to tell you all about sort of this latest technology, we have an expert, certainly not me. We have Dr. Julie Rodman, who's a professor of optometry at Nova Southeastern University and the chief of the Broward Eye Center, Eye Care Institute in Fort Lauderdale. And of course, her research interest includes OCT and OCT angiography. If you've ever taken CEwire, you know that she's one of our premier speakers at the course, and you may have seen some of her OCT lectures there. So I can't think of a better person to sort of talk to us both about the science of these wellness scans and also the practice management aspect as well. So Julie, thank you so much for being here tonight, and I will turn over control of the slide deck to you right now.
So thank you, Adam. Thank you, ODwire. Thank you for hosting us tonight. I'm excited to be here because for those of you that know me, you know how passionate I am about OCT and OCT angiography. And I've been working with Optovue, which is now under the umbrella of Visionics, for many, many years. And I'm very familiar and passionate about their technology in specific. So the topic tonight is really going to be wellness and how we can best integrate or best take care of our patients with this technology. Okay, so I'd like to start off the webinar with this question. Are you ready to take a proactive approach to eye health care? And essentially what this question means is, are you ready to find more disease? Are you ready to utilize your OCT to the highest level, which is what we're going to talk about tonight? And in turn, are you ready to advance the level of care that you're providing in your practices? The fact that you're on here tonight means that the answer should be yes to all of those questions. So, pardon me, let me go back. So why wellness? When this technology was created many, many years ago, the idea, which Adam alluded to, was that this printout or this piece of information that we got from the machine would provide us with a preemptive view of what was happening to the patient before we even saw them. Okay, so we were getting this kind of sneak peek into the health of the eye. And the technician essentially would go, they would take this maybe with a fundus image, and the doctor would look at this printout. So they had, you know, almost like, you know, they're a genie, they know what they're going to see before they even went in. And what this allowed us to do was really to deliver a higher level of care because, as we all know, OCT is outstanding at picking up things that sometimes we miss clinically. The other thing that is very important to optometrists is obviously we need to make a living. And so by using this technology, we're going to pick up on abnormalities that perhaps need further workup. So maybe the patient's going to have to come back to do more advanced OCT testing. Maybe we're going to order OCTA testing. Maybe we're going to bring them back for very specific fundus imaging. So with this test, with this wellness scan, it's going to open the door to many more monetary purposes or monetary value in the practice. So this is essentially one of the printouts. There's different types of printouts from the wellness scan. This one is a printout of just one eye, but there is a way that you can get a bilateral report as well. So I want to walk through what the printout shows so that when I start going through examples, it'll make more sense. So what you're seeing here on the top of the scan are essentially two very large B scans. One is a horizontal scan, one is a vertical scan. And then in the center of the printout, you'll see 7 additional horizontal scans. And really the beauty of this wellness report is that, as we all know, OCT is a dynamic instrument. So to just look at one image is really useless. We need to get a whole myriad of images to make sure that we're not missing anything on the exam. So the top will be the 2B scans, the middle are additional scans that essentially if you just touch on them, it will blow up the picture and will allow you to visualize that B scan in more detail. On the bottom left, we have a full retinal thickness map. This is measured on a micron scale. So what you're seeing there's a kind of a number line on the right-hand side, which is showing you really a color-coded way of identifying thickness. So we want the patient to be somewhere in that yellowish-greenish range, which is essentially normal retinal thickness. And that will obviously vary depending on what the pathology is. In the middle bottom of the scan, you can see how these thickness values compare to the normative database. So if you have a red value, essentially less than 99% of the population is going to have a thickness value of that number. And on the same token, if you have a blue one, that's pretty thin. So this is again comparing these thickness values to the population, to the normative database. And I will say that Optovue has a nice population of patients that they looked at when they were creating this normative database. So it's a nice, robust database. On the right-hand side, you can see the GCC analysis. And the GCC analysis is very, very nice because it provides us not only an assessment of retinal health, but also of optic nerve health, because we know that the ganglion cells perfuse the optic nerve head. So this has really been used tremendously now in the analysis of glaucoma and really on picking up on early glaucomatous damage. And then on the bottom, we have just parameters that are going to correlate with that GCC map. So understanding that the retinal ganglion cell thickness of around 85 microns and above is what we're looking at. And then things that fall below that perhaps are falling outside of the normative database, and then we have to become diagnosticians to figure out why that's happening. And I'm also going to go through some specific parameters here that are really owned by Optovue and are spectacular, splendid parameters when we're beginning to understand how to use these scans for OCT, for glaucoma analysis. So what might you uncover? Well, you can uncover a whole myriad of conditions, both retinal, neurologic, so things like AMD, diabetes, glaucoma, and my favorite, which would be diseases of the vitreomacular interface, specifically because these tend to be much more difficult oftentimes to diagnose on clinical exam alone. So step one in this is realizing really that what we think is a healthy population really may not be. And I think, or I know that one of the questions that is posed to me many times when I talk about OCT is, Julie or Dr. Rodman, I work, in a practice where my patients are healthy and I'm really not seeing very much pathology. And my answer would be that I bet you there is a lot of pathology in your practice that maybe you're missing, because as I said before, OCT is better than I am at picking up things. So I once again pose this question of what would happen for a day if you were to put this technology into your practice? How much pathology would you find in what you think might be a very healthy patient population? So let's start off with this case. This is a patient that comes in with 20/25 vision, and this is the fundus image. And looking at it really grossly, I don't see anything that yells out to me. So let's say this is a healthy patient. They're, let's say 20, let's say they're 40, 45 years old. So they don't have lenticular changes that would be explaining the 20/25 vision. And they're asymptomatic, right? So they have a slightly reduced vision, but yet fundoscopically, really not impressed that there's anything that's yelling out to me. And so this is kind of one of those cases where you say, well, let's grab an OCT because perhaps there's something that, once again, I'm missing on clinical exam. And I mentioned before that my favorite thing to use any OCT scan on is to detect abnormalities of the vitreoretinal interface, specifically because they're very difficult to pick up on clinical exam. So what you're noticing here is a patient that has a focal form of vitreomacular traction, which we all know can cause very minor, subtle obscurations in vision. This patient also has some outer retinal abnormalities as well. So if you didn't have an OCT and you didn't have a legitimate reason why this healthy 40, 45-year-old was 20/25, then this might necessitate further evaluation by another doctor. So why lose the patient to somebody else? One thing I do tell my students all the time is don't sign off on a chart in a patient that has decreased vision that you can't quantify. So don't lose patients if you have a technology that can allow you to get kind of this preemptive look or this non-invasive look into the back of the eye. So on that note, find a lot more retina disease in your practice. So let's look at some examples of retinal disease that you might find. So this is case study number 1. This is a 57-year-old who comes in really for routine eye exam. And once again, I like to say this is a relatively young patient, right, 57, and they have mild vision reduction. So here's the fundus image, and same thing, no apparent disease. Nerve looks pink and healthy, retinal vasculature looks fairly normal, macula looks fantastic. So what's the problem here? So this is the wellness scan. And let's take a minute to just kind of talk through what we're seeing here. So once again, on the top, you can see that there is a horizontal and vertical B scan. And don't ever just look at one cut. Make sure you're kind of scanning through all of the images. And what you'll notice here is this patient has two things going on. They have some interretinal disease, or I should say disease of the vitreomacular interface, which is vitreomacular adhesion. I don't believe that that's the reason why the patient is having reduced vision. Those tend to be asymptomatic. And then the patient has some outer retinal disease as well. So you'll notice some undulations at the level of the RPE, which are essentially drusenoid deposits. And this is a fairly young patient to have drusenoid deposits, and these are so small that we're not picking up on them fundoscopically. You'll notice that the full retinal thickness map is essentially normal. You know, there is some yellow areas there that may look like they're kind of out of the normative values, but this is a fairly normal thickness map. And the ganglion cell complex is normal because our inner retinal, meaning the neurosensory retina, is healthy in this patient. So this gives us a nice example of how this, once again, preemptive analysis of this patient provided us with visualization of the vitreomacular interface in the sense of some vitreomacular adhesion and also some drusenoid deposition. So this would be a patient that I would recommend bringing back for more advanced testing. And so here we talk about, you know, cost value relationship. You're going to bring the patient back to get perhaps a 21-line raster or a cube scan, or something that would allow better visualization of that outer retinal tissue, particularly because they are a young patient. So RPE disease is discovered preemptively, affording the option of early intervention and ultimately improving patient outcome. Case study number 2 is a 67-year-old, also comes in for routine eye exam, complaining of reduced vision and some metamorphopsia in the right eye. And here is the fundus image. And this one's a little more obvious now that we have something clinically significant that's happening here, okay? But let's say that you maybe got the fundus image after you saw the patient, or maybe you were relying specifically on your wellness scan, or maybe you looked at this fundus image and just didn't know what was going on. And I will say that many of my students will look at a picture like this and the differential diagnosis is broad. You know, maybe they think this is exudate. Maybe they think this is drusen. Maybe they think it's a disorder of the vitreomacular interface. So perhaps many of us would look at this and not be 100% sure what's going on, although we can discern that there is an abnormality. So this is where the OCT wellness scan is going to provide us with integral information, because here you can see that this is not exudate, as the neurosensory retina looks essentially normal, and I'll go back to that in just a minute. And this doesn't look like drusenoid deposition because the outer retina is healthy. So this patient essentially has a very significant epiretinal membrane causing a change in the retinal thickness. That doesn't mean that the neurosensory retina is unhealthy. It means that this epiretinal membrane is causing some changes to the retinal anatomy. So you'll appreciate that on the lower left, the full retinal thickness map correlates with this. So you can see that there is yellow, there is this bright yellow because there is retinal swelling as a response to the contractile forces of the epiretinal membrane. And the ganglion cell complex also looks abnormal, meaning it is thicker than normal. The micron thickness there is red because of the contractile force, once again, of the ERM. So really nice example of a patient that has a presentation that may look consistent with many different etiologies, and this drives home the diagnosis for you. Here's another great example of a 67-year-old white female who comes in asymptomatic. And if I give you a second to kind of look at the photos there, hopefully you'll appreciate that there's something wrong with one of the eyes. And maybe you won't appreciate it, but most importantly, whether you do or don't appreciate that there's an abnormality, fundus photos are taken and we're going to follow up with a B scan or an OCT scan. So I highlighted on the left there the abnormality, and certainly now that I'm kind of highlighting it for you, you can see that there is this kind of greenish grayish area temporally to the macular area. And once again, if you're not sure that what that was, or maybe you didn't appreciate it, this wellness scan is going to say, doc, look, there is something wrong with this patient. And so you'll see on top here, this is a bilateral report, so it looks a little bit different than the report that I showed initially, but you can see that the right eye does not look like the left eye. The left eye has a nice foveal pit, and all of the layers look pretty nice. On the right eye, you can see that there is a elevation centrally. There's some hyperreflective material in the outer retinal space living above the RPE. And so this is a patient that we suspect may have a choroidal neovascular membrane. So really nice example of, number one, maybe we missed it on clinical exam, maybe we missed it on the photo, but the OCT is tapping us on the back and identifying a very significant problem that this patient has. The retinal thickness map is kind of suggesting, or not suggesting, but it's driving home that point that there is a retinal thickness problem correlating with that possible choroidal neovascular membrane. And you can see that the left eye, the values are much more normative in that green range. Another nice example of retinal disease, 70-year-old with long-standing visual reduction due to lenticular changes with no new visual complaints. So you're suspecting, you're going to go in and this patient is going to have a normal exam. And this is the fundus image. I will say it again, it looks pretty unremarkable to me. Macula looks nice. Optic nerve head really pink and healthy, might be a little on the larger side, but essentially a fairly normal fundus image. And here is the OCT. And really, second to vitreomacular disease, which I prefaced by saying is one of my favorites, this is my second favorite thing to find on OCT, because I'm always so blown away when it's not so clinically apparent, and then I get an OCT and I see central serous. So this is idiopathic central serous choroidal retinopathy. And maybe now when I blow the image up on the left, you can appreciate that there looks like there might be some elevation there. But God, if you were looking at the fundus image in an asymptomatic patient with essentially normal vision for their age, is this something that you would see? If you had done the wellness scan preemptively as part of, let's say, their screening, you would have picked it up. Okay, and this would be a patient that we would want to bring back, or perhaps even on that day, due to the acute nature of the presentation, get some more images and thus charge an additional fee for the additional images that we're going to do. You can also see the thickness numbers on the bottom left are a little bit outside the normative range. You can see how it compares to the normative database on the bottom of the image. And once again, the ganglion cell complex is a little abnormal as the neurosensory retina is elevated due to this, this detached area. Another one here, 74-year-old with a long-standing history of dry AMD. This is a smoker, and I always find this entertaining that they tell me, Dr. Rodman, I don't smoke very much, but they smoke 3 packs a day, and that's always quite entertaining, because maybe at one point in time they were smoking 10 packs a day, who knows? But given this history, maybe we're thinking that something is going to appear clinically. And why I'm including this is because I want to show how these scans could really help us track patients as well. So I gave a lot of examples of really kind of presentations that we're seeing acutely that day. But what about if we had a patient that we were following consecutively or sequentially over the years? So here's a patient that we saw in 2009. The patient knows they have AMD. You can see on the clinical exam, again, top left, that this patient has drusen, they have RPE pigmentary abnormalities, which puts them in the intermediate stage of AMD. On the right is the 2010 photo. It doesn't take a lot to notice that the drusen deposits are getting larger. There's still those pigmentary deposits. Those are not going to go away. And then in 2011, to me, it does look like it's continuing to progress. But what if you wanted to get a quantitative assessment, right? What if you didn't want to just eyeball this, but you actually wanted to have a quantitative way of assessing the size of the drusen, the amount of pigmentary deposition that there was? Because in AMD, drusen size is critical. Pigmentary changes are critical. So sometimes it's not enough just to look at the image or the photo. So the OCT has the ability to kind of show you this trend analysis over time, and it'll automatically line up the images from visit to visit. So here you can see that we have, the scan from 2012 on the top. We have the scan from 2013 on the bottom, and it shows you exactly parallel those locations on the retina. So you can appreciate how specific areas of drusen are changing over time. And something that is quite interesting in this patient is that the drusen, you can definitely see that there's some elevation and enlargement both in height and width of the drusen, but there actually also is an abnormality affecting kind of the interval between the photoreceptor integrity line and the RPE. And this is an area where there may be the development of some type of carotid neovascular membrane. So perhaps that might be something that we couldn't see just on clinical exam. So having this trend analysis is really essential to monitoring these patients and checking for the progression of the disease. What about diabetes? So I just spent, a little bit of time talking about all these retinal conditions, and diabetes obviously goes into the category of retina, but there's some new terminology that really relies on the use of OCT when you're managing diabetes. So this is a patient that has what we used to call clinically significant macular edema. And I always found it such an arduous task to memorize the definition of clinically significant macular edema. And so the ophthalmological community was brilliant in coming up with this new term, which really relied more on the use of OCT to make a diagnosis of macular edema. So we call macular edema now either center involving or non-center involving diabetic macular edema, which is really much easier to remember and understand than memorizing the definition of CSME. And you do need an OCT, you need B scans, you need thickness maps to make this determination. And it's super important to understand if it's center involving or non-center involving, because that's going to really determine, number one, the management of the patient, and ultimately what the visual prognosis is going to be. So here's a patient that you look at, and it looks like the patient has some background mild diabetic retinopathy, maybe one larger dot and blot heme superior. This is a patient that's 20/20, and before that advent of OCT, this would be a patient that I might bring back in, let's say, 8 months. Nothing that is yelling out to me that this patient has poor control of their diabetes. However, we get an OCT scan and you're not surprised that we're missing something. So we're seeing here that this patient has some diabetic macular edema. And, based on the old definition of CSME, we would have to see some thickening, some exudate, and it's really just not apparent on the fundus image. However, there is something going on the OCT wellness scan. And if we look at the thickness map, on the bottom, on the left-hand side, you can see that some of those parameters are definitely elevated. And looking at that center 1 millimeter subfield that says 357 is certainly out of the normative range it's being identified as red in color. That would really indicate that this is a center involving diabetic macular edema, and that's difficult to really appreciate on the clinical exam or on the fundus exam. So having these OCT images, having a retinal thickness map is essential if you're trying to determine whether these are center, first of all, if there's even diabetic macular edema, and then if there is it center involving or non-center involving? So once again, I kind of show, because I can't believe it when I look at it, that this patient does have diabetic macular edema, and looking at that thickness map, particularly at that 1 millimeter central subfield, is going to help us to make the determination on whether that macular edema is center or non-center involving. And then glaucoma. So, I spent a lot of time talking about retina. Don't forget glaucoma and the value of the wellness scan, the value simply of OCT in the management now of glaucoma. And the studies are actually telling us that, in the early to early or moderate stages of glaucoma, OCT actually beats visual fields in early diagnosis and detection of glaucoma. So integrating and understanding how to use these scans in our glaucoma patients is really essential. So starting off with this case study here, this is a 60-year-old Hispanic female with a strong family history of glaucoma. She's got two sisters, and we know that having siblings that have the disease is actually very powerful in determining whether or not you may develop the disease. The patient's IOP ranges from 18 to 20, and pachymetry is essentially normal. So, looking at these these optic nerve head images, there definitely is cupping here, right? So we can see that there's cupping. The optic nerve heads look a little bit large, but really this is something that we all face every day. We look at these and we say, is this glaucoma? Definitely there's cupping, but there's a lot of patients that just have physiological cupping that do not have glaucoma. So here is a wellness scan on this patient. And we can see that the B scans look essentially normal, right? The top images all look normal. The retinal thickness map looks normal on the right eye, right? All the values are in the green. But what about that left eye? The left eye is picking up on something that maybe we did not pick up on our 3D or our optic nerve head assessment. And you can see that the ganglion cell complex is red. There's a big red defect on the GCC. And you can see that there's some abnormal numbers in the normative database area as well. And I mentioned before that what we're looking for as far as GCC numbers are 85 and above. So when you see the right eye, the numbers are really nice there, 94 being the total ganglion cell complex thickness. Superior and inferior look pretty good as well. The left eye is showing an abnormality. The left eye is showing an 82 total thickness, with the superior GCC being extremely thin. And this FLV and GLV value, which we'll delve into in just a minute, are also outside of normal limits. So what is the purpose, or what is this trying to tell us, right? What are these values telling us? Well, they're certainly tagging something in that left eye, and it is worthwhile to investigate, because as you can see on the B scans, there's really nothing in that left eye that would go along with having an abnormal GCC or an abnormal reason for substantiating an abnormal GCC. So we have to start thinking outside the box, thinking along the line of maybe there's something going on in that left eye. So here I have, once again, just the GCC images from that previous printout and the optic nerve head photos on the bottom. And what does this all mean? How do we put this together? What is this telling us? What is this picking up on for us that maybe we can't appreciate clinically? So just to spend 1 minute on FLV and GLV, because these are exclusive terms that belong really to Visionix Optovue. So FLV is, to me, the more important one, but I will delve in just a second to both. So FLV stands for focal loss volume. The way I like to think about it is that glaucoma is a disease that causes focal abnormalities. So if you look at a visual field, we look for focal or cluster defects, areas of abnormality. So what you're looking at is, if you were to take a pie and you were to cut out a wedge of that pie, that would be a focal abnormality. So what this number is doing is it's looking for focal defects on the GCC map. And it actually kind of correlates with, on the visual field, the corrected pattern standard deviation feature. And I'll show you in just a minute how we can use that value. The GLV is the global loss volume. Global loss volume looks at generalized depression. So instead of looking at focal areas of abnormality, it really just compares you to the normative database as the mean deviation would on visual field. So how does this patient compare to everybody else their age? So if you were to look at, why is this important? I'm going to skip this slide. It's a lot of words, but I want to show you the graphs. So this is specifically looking at FLV, okay, because I think FLV, like I said, is in my clinical experience more useful than GLV. So if you have a patient that you're looking at conversion, so maybe it's a glaucoma suspect. Okay, we'll look at this one first. You have a glaucoma suspect and you want to know if this patient is at risk for converting to glaucoma. If they have a normal FLV, the blue one, they only have a 10% chance of converting. But if they have an abnormal FLV, meaning it's yellow or especially red, they have a 41% chance of converting. So that's pretty powerful, again, in a glaucoma suspect, let's say. What about a patient that already has glaucoma? What are their chances of progressing in the disease? So if their GCC stays normal, their FLV stays essentially around the same as it was, they only have a 30% chance of progressing. However, if that number is showing sequential changes, then they have a 60% chance of progressing. So using these tools or looking specifically at the FLV is extremely helpful in determining which patients are at risk for developing or moving on to develop or progress in their glaucoma. And this is also keeping in mind that because GCC can also correlate with retinal disease, we have to make sure that we are ruling out corresponding retinal disease that might be causing an abnormal GCC. So in the absence of retinal disease, and we're looking specifically at optic nerve head disease, these are pretty powerful numbers. So just to kind of put this into play, this is an example of a patient that we run the test on because they're cupped, okay? So almost like the patient I just showed you. And looking at the parameters in that left eye, if you scroll all the way down to the GCC analysis, you can see that the FLV is yellow in that left eye. So what would that tell us? Well, it would tell us that because this patient is a suspect, they have upwards of a 40% chance of converting to glaucoma in the absence of other retinal disease that could explain that FLV. So this is not a patient that I would dismiss. This is a patient that I would watch fairly closely due to that abnormal FLV value. Trend analysis in glaucoma also is really great with OCT. So here's a patient that we see in 1988, and it doesn't, it's very difficult to look at, 1990, 93, 95. Do we see evidence of change? And I'll say, I'm sure you guys all know this, it's not always the easiest to look at patients and appreciate change just by looking at stereoscopic images. Sometimes it's obvious, but sometimes it's not. And this is where, visual field is good. I think OCT is even better. So on the bottom of this image, you can see how this patient has changed or progressed over the years. This is an arcuate defect that's becoming more and more inclusive or, involving of that superior field over time. But you can also look at this in a quantitative way on OCT. So what you're appreciating here is not only an RNFL assessment, but a GCC assessment. And the little blue dots that you can see on the grids on the bottom are showing you every single time the patient comes back and how stable the condition is. And looking kind of at these color-coded metrics, if you see the dark purple here, is actually an indication that this patient is progressing. And what's really neat about this is by looking at this, it's not obvious that this patient is progressing. But looking at the trend analysis on the bottom, it becomes much more obvious. And using these tools, if you're not familiar with them, is really very powerful in making these good clinical decisions. So I want to kind of switch over on to anterior segment OCT for a minute, because I think this is the child that is most often forgotten on OCT. And I will emphasize that it is awesome. OCT is awesome at doing some anterior segment images. So Don't forget that you can do pachymetry using your OCT. So with a simple attachment that goes onto the front of the machine, you can measure pachymetry. You don't need to buy a separate pachymeter. If you don't know how to do this, you're always welcome to reach out to me and I can walk you through the process. But really, really great how you almost get like a topographic map there showing how thin this patient is centrally and inferior central. But you also can see that the pachymetry is thin in this patient, measuring at 441. You can also get great images of the cornea. So here's a patient that has obviously a corneal abnormality. Maybe you're not sure what it is. Maybe when you look at it, you're not sure, is it epithelial? Is it stromal? Is it endothelial? I will tell you that this patient has mutton fat KP, but what if I didn't know that? Well, I can do a beautiful corneal section of this patient. And what you can appreciate here is that the epithelium and corneal stroma are unaffected, but yet there is some abnormality at the corneal endothelial layer. You can see there's some hyperreflectivity and almost some deposition there, which is correlating with that keratoc precipitate. So if you weren't sure, maybe you were thinking, oh, this could be granular dystrophy, or maybe this is another type of stromal dystrophy. This would kind of help you to hone in on the endothelium and help you hopefully to appreciate what this patient has, or at least lead you in the correct direction. On that note, this is a patient that has granular dystrophy, and it looks very similar to the previous image that I just showed you, but look at the difference in the OCT image. Here you can see that the endothelium is not affected, but the corneal stroma is affected. Right, so here you can see these large hyperreflective opacities in the corneal stroma with kind of lucid or clear intervening spaces between the opacities, which is something that we see in granular dystrophy. And if you didn't know what it was, you could at least see that this is a stromal problem, and maybe then you could start to look up some of the corneal dystrophies that affect the corneal stroma. What about looking at the corneal epithelial map? So this is something that is extremely helpful in doctors that are doing, keratoconus or pellucid, or they're trying to really figure out what is happening at the epithelial level. And I will say that this is extremely helpful if you're trying to make a referral to a doctor for cataract surgery or something. You want to make sure that these patients have a healthy cornea. So using these measurements is extremely helpful. And if you're co-managing with refractive surgeons, these are tools that are extremely useful to either share with them or just make clinical decisions on your own. Something that I love to use OCT for is angle measurement. So what you'll notice on the left-hand side there is what a normal corneal angle looks like. So what I usually have the patient do is look towards their nose to get one of the angles, and then look in the other direction to get the other angle. That kind of makes the cornea more, it takes away any obscuration that you might get from the corneal interface if you have them look sideways. And then I line up that little caliper on the arrow right at the limbus. And what you'll see there is that, at least on the top scan there, you'll see the cornea on top, and you'll see the ciliary body band is that bumpy area on the bottom. And when we measure the angle, we're going to place our caliper right into the divot there, into that triangular space. And this machine will automatically measure the angle for you. On the Optovue, anything below 15 degrees is an includable angle. So the closer that corneal interface is to the ciliary body band, the narrower the angle is. And you can see on the right-hand side what a narrow angle would look like. So this is really a fantastic utilization. There are tons of patients that can't fit into the slit lamp. Maybe they're not able to due to arthritis, or maybe there's weight limitations, but this is a great way to utilize this technology in a patient that perhaps you can't do gonioscopy on. It's also a really great provocative test. So if you measure the same patient in under light and then dim conditions, you can test how close this patient is to going into angle closure in a dim environment. So this is a patient that we did on the top in light, under light conditions, and you can already see that the angle is extremely narrow. That interface between the corneal endothelium and the ciliary body band is extremely narrow. This is barely, probably 7 degrees. But look at what happens down here under dark conditions. That angle almost becomes completely occluded. So this is a fantastic test to do in-house, doesn't require any compression gonioscopy, to really test and see what's going to happen in almost a provocative test to see what happens in a dark setting. And really the last part of this webinar, and then I will open it up to questions, is to learn to implement Angio Wellness. And so for those of you that are not familiar with OCT angiography is providing a new dimension to our analysis of patients using OCT in a non-invasive way. So we know that OCT provides structural information. OCT angiography is going to provide what I call functional information, meaning how healthy is the vascular supply to the eye. So using this will allow us to look at the retinal vasculature, not only of the retina, but also of the optic nerve. So to go back on how we started this presentation, the wellness map is allowing us information about the retina and the optic nerve. And so the Angio Wellness exam is taking the wellness exam to the next level. It's putting together structural information that our normal wellness exam provided and adding on the angio piece. So you're getting this kind of screening information at both levels, structural and functional. So when we look at essentially the Angio Wellness printout, which I'm going to show you in just a minute, there's two things that we focus on. We focus on the vascular supply surrounding the optic nerve head. So you can see the images on the top are what we call the radial peripapillary capillary vascular network. So the nerve is in the middle, and this angio scan is showing us on a percent saturation scale how healthy the vascular supply is surrounding the optic nerve head. We want that area right around the nerve to be yellowish orangish. That means there's a very high vascular supply. As you move further out from the optic nerve head, you can see how the colors become darker because that's normal. As you move away from the nerve, there's less vascularity. And when you're looking at glaucoma, we're looking at the papillomacular bundle. So the papillo piece of that is the radial peripapillary capillary vessel network. The macular piece of it is the bottom images. That is the retinal piece, showing you really the fovea, which is that kind of navy area in the middle, and the vascular supply in that paramacular area. So once again, you want the fovea is going to be navy because there's no vascularity there, and the area around the fovea is going to be a nice warm color. In order to really look at diseases like glaucoma, you have to look at not only the optic nerve head or the radial peripapillary capillary network, but also the vascular supply, the macular vascular supply, which we call the superficial vascular complex. So you'll notice that the wellness scans are going to give you printouts of both of these structures because that's extremely important in the analysis of these patients. So it's a phenomenal addition to the wellness scan, the wellness report that we spent the beginning of this talk talking about, because now it's integrating the vascular supply as well in a non-invasive way. So you can see on the left side what a normal, as I showed you on the previous slide, normal radial peripapillary capillary network would look like, both on the disc, and then the superficial capillary plexus of the retina would look like underneath it. Both of them really, really nice perfusion, nice warm colors. You'll appreciate here that as we start to delve into glaucoma, the color scale, the vessel density, the saturation, whatever you want to call it, is beginning to change. So those warm colors are beginning to turn more into the navies, darker greens, because there is a less robust vascular supply feeding into the optic nerve and that papillomacular bundle. So in moderate glaucoma, you can see it's blue, and then look at how navy and how we kind of get depleted of the vascular supply in advanced glaucoma. And patients that have wedge defects will manifest wedge defects that are blue. It'll readily identify areas of ischemia or poor vascular supply in areas where there is RNFL defects or RNFL defects. So let's put this into play here. If you have a 45-year-old African-American female here, She has an A1C of 7, and we know that an A1C of 4 to 6 is really where we want to be. She's been diabetic for 10 years, and she tells me that she has excellent blood sugar. And you can see fundoscopically that she really looks really good. You know, she may have 1 or 2 little microaneurysms, putting her in the mild NPDR category, and her OCTB scan looks essentially normal. So if we were to do a wellness scan on this patient without angio, I'm anticipating that most of the parameters would be normal on this patient. However, what it doesn't take into account is what's happening at that subclinical level. What is the vascular supply to this patient? After all, her A1C is elevated, and she's been diabetic for 10 years. And we know that the longer the patient has diabetes, the more prone they are to developing retinopathy. But yet this patient, at least from the clinical perspective or the structural perspective, looks very clean. So here is what an Angio Wellness report looks like. So you can see on the top there are our B scans, which we're not expecting to see anything because she really doesn't have anything going on clinically, at least on fundus exam. You can see that her GCC maps look healthy. Her retinal thickness is 118, 117, really, really good. But what is the angio providing for us? What is the angio map on the bottom kind of adding to the picture? Well, it's providing great information because it's showing us that this patient doesn't look as good as perhaps we thought they did. So here's a patient. So what does this mean? Here's a patient that's normal. And what I'd like to do is kind of show you side by side what this patient, what the angio of a normal patient would look like next to the angio of this patient that I showed you. So this is our patient. And let's look at them side by side. So here's the patient. On the top is normal, and on the bottom is this patient. And what you'll appreciate is that those retinal vessel density numbers are certainly not as robust. There's a lot more navy in the images. There's not as dense of a capillary network. And so what this is adding to the picture here is that you might have thought that this patient was doing really well. You might have dismissed them and told them to come back in a year based on really a very normal B scan and really, really normal clinical appearance. However, having the wellness piece or having the Angio Wellness piece onto the wellness map or onto the wellness report is providing another dimension or another piece of information, showing us here that this patient is probably going to go on to develop retinopathy due to the ischemic situation that's happening at that vascular level. So I think, Adam, we can open this up to questions if there are any. I know there was a lot of information, and I'm happy to go over anything that anyone may have.
All right. Well, thank you so much, Julie. That was a really incredible overview of the wellness scans and what you can do with it. I actually learned a lot that I did not know. And I thought I knew a bunch, but I was wrong. So thank you for that. So let me actually bring up people's questions. Remember, you can ask a question by clicking on the question box and typing in your question there, and I will ask. And let me pull out my question box here, and I can see what people have asked. And so let's see. So practice management question, I guess. This is a good one to start off with. So in your own experience, do you do these wellness scans on every patient that comes through your door or a subset of them?
Well, what I will answer is, I'm in a different setting because I'm in an academic setting, but the practices that are doing the best using this technology are offering it as part of a package. So what they'll do is they will offer a wellness scan with, let's say, a fundus image, and say to the patient, this comes in a bundle and charge X amount of dollars, and they'll do it on every single patient. And that's really the idea behind this, is that you want to capture this information preemptively to provide as much information to you before you even see the patient. So ideally, yes, you would do it on every patient as part of essentially this package or this screening exam that you offer to your patients.
Right. Question here, this is again another practice management question. Those images of the angle that you showed, are those billable as gonio or as an anterior segment photo or in some way?
Yeah, so I mean, I would code it as an OCT. I mean, I know when you do it, you can code, OCT retina, OCT optic nerve, and there is actually a way of coding just general OCT. So I would say yes, I would I would certainly code, I would certainly bill it and charge it. I would have to find the exact ICD-10 code or whatever it is for you, and I'm certainly happy to do that. I don't know it off the top of my head, but yes, any procedure you do on OCT is billable. OCTA is not a separate billable procedure, so doing OCTA has to be billed just with as part of the OCT scan, but you can certainly do charge for an anterior segment OCT.
Right. And another practice management question, do you have some sort of a script that you give to staff to use, when you want to give patients a wellness scan? How do you actually do that, talk to the patient about it?
Yeah, I mean, it's really telling them that this technology is going to allow us to get much more information than we would get just on clinical exam alone. It's almost like when you go to the dentist and they get an x-ray. It's giving information that perhaps the dentist can't see just by looking at your mouth. So it really provides, a maximum level of care that, most practices aren't offering. So you're setting yourself to a different level or a different standard than perhaps your colleagues. But that's the way I would say it, that we want to provide this level of care that's going to allow us to see or give us much more information than we're going to get just on clinical exam alone.
Right. A question here regarding the very last case that you presented. Question is, when would you see the patient back and repeat the angio, and what would you recommend the patient do other than sort of the obvious?
Yeah, that's a great question. I'm asked that a lot because, you code and you make your clinical decisions based on your fundus examination, maybe on your OCT. So, we would say to that patient, well, you have mild NPDR, and then you go and you do angiography, and it opens up a whole nother group of questions. And so how do you kind of change your management? So if you were going to see the patient back in a year, I probably would see them back sooner, but the most important part is the communication, not only with the patient, but with the internist, because, you might have initially said, Mr. Jones, you're doing fantastic. Your fundus image looks fantastic. I don't see anything, very little signs, but the truth is he's not doing as fantastic as we thought he was. And so I think that the most important part is the education to the patient and the internist. So my answer is, I would see them before the year alongside changes or modifications in behavior, right? It's not going to make a difference if the patient's going to continue doing what they're doing, because they're just going to keep going downhill, but hopefully modifying their behavior and then seeing them back sooner.
Right. Yeah, because that's a follow-up question that someone had here. If you have a diabetic patient where you're starting to notice these changes, do you actually adjust your recall schedule?
Yes. Yes. And showing the patient, I mean, these color-coded images are very easy to understand. And, telling a patient warm colors versus cold colors is actually much easier for them to understand than an OCTB scan. So showing them these, vessel density maps is actually very powerful. And there is a way to look at vessel density over time as well.
Right. Interesting question here. What's the minimum practical age for someone to get a scan? This person said they find fundus photos are really challenging when you get someone below, say, age of 8 because of fixation issues.
Yeah, I mean, I don't see that many kids, and so it's not the best person to ask. But obviously, you try to get it on as many patients as you can. If you can't, you can't. I think that pediatrics are hard. That's a very hard population. Sometimes the Optos is actually the easiest way to get a fundus image on those patients. It's difficult. And my answer is you try the best you can.
Right. Yep. And let's see. Oh, question here. I guess this is more of a practical question. So when we take OCT angles, sometimes we have difficulty getting to the limbus. I think you said to ask the patient to look towards the nose for the temporal angle and then away for the nasal angle. Is that correct?
That is correct. I mean, that's going to flatten out the corneal plane. What I find is that if you have the patient look straight ahead, it is often very difficult to get a great image on the limbus. I find I get obscuration. So having the patient look sideways is extremely helpful. Remember to make sure to illuminate the eye with there's like a little light, obviously, that comes with the unit. Make sure you're illuminating the eye very well, and have the patient stay as still as they can. Moving around is hard because then you hit the iris. So these things are also all patient dependent. So I agree with you. It's not always the easiest thing to do in the world, but you can get a nice, even if they're moving, you can get a pretty good assessment of the chamber depth. So.
Right. Someone made an observation here that some insurers, like Blue Cross Blue Shield, don't pay for anterior segment OCT, only gonio. So I guess that begs the question, sort of, different insurers do handle things differently. I suppose once you start doing this, you'll get a very good sense of which ones do what.
Yeah, you know what? I haven't. I mean, I'm gonna again. I don't do my own billing. I'm in an academic, setting, but I've never had an issue billing an anterior segment OCT. Maybe they. I mean, maybe we're just. It's under a general code. I'm not sure how, if the way you code it makes a difference. I could find out how we're doing it, but I know that you can charge for anterior segment OCT, because if you're doing a corneal scan, you're certainly not going to charge the same way, and you're not going to code the same way you would for a retinal OCT. So I could find out that answer if anybody wants to email me, and I can get back to them. But there is a way to code it properly and get billed and get paid. But yeah,
Right.
maybe it depends on the insurance. I'm not 100% sure.
Yep. So a question here, how long does a wellness scan take with or without the angiography component?
Seconds. It's really, really fast. I mean, it's super easy. All of that information just comes from one click. I mean, literally, if you're adding the angio piece, maybe another, 15, 20 seconds. It's very, very fast.
Right. Oh, someone made a follow-up comment. It's true about the billing. Some insurance companies consider anterior seg experimental, in quotes. If you get the patient to sign ABN, you can bill the patient if denied.
There you
Okay.
go. Thank you.
So let me see. So, and if someone asks, I'm sorry if you mentioned this already, but when I see abnormal macular thickness, I often do not see anything on the individual slices. So what are your differentials, or what do you do for follow-up care in that case?
It's a great question. I will say that, remember that the colors are correlating with the normative database that Optovue used when they created the normative database. So if your patient doesn't fall directly within the normative database, their colors might be off. And so the most important thing is to understand how to look at the B scans and get good B scans, good quality, and look for abnormalities on the B scan. And the other thing I would say is that look for the bilaterality. So if you have a patient that has refractive errors that are fairly similar, their OCT thicknesses should be fairly similar on the thickness map. So if you have, like I showed you an example of a patient that had, one eye was green, the other eye had kind of, some blue, some red, that might be a warning sign, because the thicknesses in a patient that has the same refractive, almost the same refractor, should be fairly the same. So keep in mind that those colors are only a gauge as compared to the normative database that Optovue use. That doesn't mean that your patient's abnormal. That is a question that I get consistently, is people send me images because the colors are off. Having abnormal colors doesn't mean that the scan is abnormal. So you have to use everything together to make a good clinical decision.
Right. And question here, at the top of each one of the scans, there was a little meter that said good. It was in green on your scans. How often is that not green? And how often do you actually have to repeat the scans?
Yeah, I will say most of the time it is green. If you get, the brighter the reflectivity of the image, the more white the image is, the better the quality. So if you're looking at an image, and this is true of any B scan, if you're looking at the image and it looks washed out, then it's hard to analyze it. And so, you don't even really need to look at the scan quality or the color. You can tell yourself if you're looking at it and it's washed out and it has a lot of obscuration, then obviously that's not a good scan and you need to repeat it. But I'm going to tell you the truth, with regular OCT scans, most of the time, it's not that hard to get a good quality scan. OCT angiography is more challenging. But OCT, if you keep artificial tears near the machine, usually you can get a pretty good scan on a patient.
Right. And we have time for one more question here. This one I bet you're not going to know the answer to. So the question is, do you get a sense of how much clinics actually charge for a wellness scan?
Yeah, that's a hard one. I can give you a ballpark, but again, it's not just the wellness scan. Usually they do wellness with a photo, and it's
Right.
probably anywhere from 50 to 100 for both. That's what I've heard. Again, we don't do that at the university, so I'm not a great person to ask, but it really is up to you. It depends on the area you're in. It depends on how much, what the economic situation is where you are. But the package deal, it seems to be the way that most private practices are going, and how they're banging it in with this, how they're really making coin on this.
Right. So I guess they'd want to ask the folks at Visionics,
Yeah.
maybe for further information. And in fact, by the way, in case anyone out there who's, you're all still watching, you're going to get a follow-up email from the system. If you have any questions for us or for Visionics or whatever, please just shoot, reply to that email, and I'll get a copy of it, and I can pass it on to the right person for you. And somebody else also asked, is this going to be archived? And the answer is yes. This should be up on ODwire sometime. Not exactly sure how quickly I can get this up, but if you go to ODwire.org, that's where this video archive should live, and you can also continue asking questions there. So hopefully we can continue the conversation a little bit. So Julie, thank you so much for taking the time tonight to do this. I think everybody learned a lot.
My pleasure. Happy to do it. If anyone has any questions specifically for me, I don't know, Adam, if I'm allowed to share my email, but I'm happy to if there's specific.
Sure. Yeah, it's up to you.
Okay. So it's the best email is Dr. Julianne, Dr. JULIEANNE @gmail.com. Happy to answer any specific questions anybody ever has. Really, my goal is to make this technology as user-friendly as possible, and I'm happy to do that any way that I can.
Excellent. So, and again, if you missed that, you're going to get a follow-up email from me. Just reply to me and I'll forward it on to Julie. So we will make sure you get it one way or the other. So thanks again, Julie. Thanks again, everyone, for showing up. And I hope everyone has a great rest of their evening.